In the next section, we'll discuss several examples of autonomic pathology. In this section, we'll talk about autonomic pathology. There are several diseases that affect the autonomic nervous system. Idiopathic autonomic failure, otherwise known as Shy-Drager syndrome, is a neurodegenerative disease specifically affecting neurons in the CNS that mediate the outflow of the autonomic nervous system. Polyneuritis, otherwise known as Guillain-Barré syndrome, is another syndrome that affects autonomic nerves. Recall that Guillain-Barré also affects motor and sensory nerves, but because of the myelination on the preganglionic side of the ANS is also affected during Guillain-Barré syndrome. Diabetes causes significant pathology in all types of peripheral nerves, motor and sensory, as well as autonomic nerves. And diabetic dysautonomia is a very common scenario. The most common manifestation of this is a diabetic gastroparesis. And diseases that cause the overproduction of amyloid often affect autonomic neurons or autonomic peripheral nerves. Shown here is a cross-section of the myocardium with a massive deposition of amyloid. Amyloid can also deposit in the autonomic nerves. In the next slide, we see a patient who has asymmetry of his pupils and a left ptosis. And one question is, what is his diagnosis? Well, there clearly is a left ptosis and a left meiosis, and this patient appears to have a Horner's syndrome, at least two of the three well understood components, ptosis, meiosis, and there's not an obvious anhidrosis. Here's some more history on this patient. This is a 42-year-old man who was robbed. He was shot in the neck, and the left carotid was damaged by the bullet. And shown on the left is a picture of the scar after his surgery. After the injury, he had a right hemiparesis and the resultant eye abnormality that we saw in the previous slide. So the hint is, what travels with the carotid? Well, the autonomic innervation travels with the carotid. So this subject, or this patient, likely has a Horner syndrome related to damage of his left carotid, which also caused a right hemiparesis due to a left hemispheric stroke. Now, very often when faced clinically with a Horner syndrome, we don't have this type of history to help us to understand the etiology of a Horner's. And so, therefore, there is a mechanism or a series of tests that one can do to work up a Horner syndrome to understand what the etiology of the Horner syndrome is. Before we describe this workup, I want to review the basic organization of the innervation of the eye. So shown on the right, in gray, is an outline of the central autonomic nervous system with the brain and spinal cord and the paravertebral chains of ganglia on either side of the spinal cord. The main innervation of the eye is driven initially via the hypothalamus, sending primary projections down from the hypothalamus into the thoracic spinal cord to synapse at the level of T1 at the intermediolateral cell column. From there, the secondary neuron emerges, sends an axon out through the ventral root, ultimately through the white ramus communicans, will join the paravertebral chain of ganglia and will not synapse at that level, but ascend this chain of ganglia and will synapse at the superior cervical ganglion found in the neck. From there, a third-order neuron will travel along with the carotid and branch at the level of the eye to innervate the pupils in order to mediate pupillary dilation. The parasympathetic innervation of the eye emerges from the oculomotor nerve. The oculomotor nerve, the third cranial nerve, will carry this parasympathetic innervation of the eye and will innervate the ciliary ganglion. The ciliary ganglion is located just behind the eye, and there you will find the postganglionic neuron which innervates the eye to cause pupillary constriction. The In the next slide, we illustrate the normal pharmacology of this system. So under normal conditions, the primary neuron, which has its cell body in the hypothalamus, will send a projection down the cervical cord, will synapse in the thoracic cord, and will release glutamate at that synapse. The secondary neuron will emerge and synapse in the superior cervical ganglion and will release acetylcholine at that synapse. And the tertiary neuron will travel along with the carotid and will secrete norepinephrine. That norepinephrine will bind to an alpha-1 receptor. The alpha-1 receptor is found on the pupillary dilator muscles, and when activated will cause pupillary dilation. Another important feature of this system is that the norepinephrine secreting neuron, like all adrenergic neurons, has a reuptake system which can be manipulated pharmacologically. So this is the normal course of events to cause pupillary dilation. If one were to apply cocaine via eye drops to this system, what might happen? Well, cocaine added to the system will block the reuptake system for norepinephrine. That will increase the amount of norepinephrine at the synaptic cleft, and that will cause pupillary dilation. If one were to find this, meaning clinically, if someone comes to your office with something that looks like a Horner syndrome and you use cocaine eye drops to block the reuptake system and the pupil dilates, the only conclusion that one can draw is that the whole system is operating normally, because cocaine can only work on a system where norepinephrine is already being released, meaning the third order neuron is healthy, where the alpha-1 receptors are responsive, and you have to know, you can assume that the primary and secondary neurons are also healthy and working, because if not, norepinephrine will not be being released. Because norepinephrine is released when the tertiary neuron is activated, and the only way that neuron can be activated is if the secondary neuron is activated. And the only way that that neuron can be activated is if the primary neuron is activated. So if cocaine works in this system, one can conclude that this patient has physiologic anisocoria, meaning the pupils are two different sizes, but there's no pharmacological abnormality or other abnormality here accounting for this anisocoria. Now it's possible that one applies the cocaine eye drops and the pupil doesn't dilate. Well, if the pupil doesn't dilate, then we know we have some pathology. The next step in the workup will be to apply amphetamine eye drops. Amphetamine works by inducing the release of stored norepinephrine. And amphetamine, therefore, can only work on a neuron which is alive and healthy and producing norepinephrine and storing it, or producing norepinephrine within its synaptic vesicles. So amphetamine, if it works to cause this pupil to dilate, this implies that the tertiary neuron has not been damaged in whatever clinical scenario causes patient to have a Horner syndrome. The other thing you know is if amphetamine works, that means the alpha-1 receptors are working and the pupillary dilators are working. But for some reason, this tertiary neuron was not being activated to release its stored norepinephrine. So what do you think can cause a neuron to produce neurotransmitter but to not release it? Well, typically this occurs when, for whatever reason, this neuron has lost its afferent innervation, meaning whatever normally innervates this neuron is no longer operating to cause this neuron to be activated, which means that either the secondary neuron or the primary neuron is lesioned. If the secondary neuron was lesioned, that means the tertiary neuron would be alive but quiescent, not releasing norepinephrine. If the primary neuron, the one that came from the hypothalamus, if that neuron was lesioned, what might you expect? You would have a living but quiescent secondary neuron, and then you would have a living but quiescent tertiary neuron. And again, no norepinephrine would be released. So getting back to the question at hand, if our patient had a pupil that did not respond to cocaine, but did respond to amphetamine, the only conclusion that we can draw is that the primary or the secondary neuron has been lesioned, but that the tertiary neuron and the actual pupillary dilators are intact. Finally, let's say that that doesn't work. Let's say that we apply the amphetamine and we got no response. Well, what can we conclude at this point? Well, if amphetamine doesn't work, that means either the tertiary neuron is just dead with lesions somehow, and if it's lesions, it's not going to produce norepinephrine. Therefore, no matter how much amphetamine you place on it, it's just not going to release more norepinephrine. Or it's also possible that maybe there's something wrong with the pupillary dilators. People could have infections or inflammation of the pupillary dilators. Something could be wrong with the alpha-1 receptors. Maybe they're just not working, and that's why the pupil is constricted. Well, one can test the latter hypothesis by simply applying phenylephrine. Phenylephrine will bypass all of the neural machinery and goes straight to the muscle. It activates the muscle simply by binding and activating its alpha-1 receptors. If phenylephrine works to activate the receptors and the pupil dilates, then one can assume that the pupillary dilators are normal. So the only source of pathology that will be left would be the tertiary neuron. So if one goes through this whole sequence, this flow chart of diagnostic tests from cocaine to amphetamine to phenylephrine, and phenylephrine is the only thing to work, one can assume that the source of pathology is in the tertiary neuron. If phenylephrine does not cause the pupillary dilators to dilate, then something is wrong with the pupillary dilators, because phenylephrine works directly at that level. There's a problem either with the muscle or with the receptors, but it's certainly a distal problem, not relatable to the primary, secondary, or tertiary neurons. So question: the left pupil of the patient with the traumatic Horner syndrome, which was described earlier, would dilate in response to the ocular application of cocaine, amphetamine, neosynephrine, atropine, pressure, or two of the above. So the correct answer is actually two of the above. It would open to neosynephrine. So neosynephrine is the brand name for phenylephrine. This is an alpha-1 agonist. It's going to directly activate those receptors. And one thing we've not yet talked about, but you should always keep in the back of your mind, parasympathetic innervation to the pupils is just as important as sympathetic innervation. And so if one were to come along and to block the parasympathetic innervation to the eye with something like atropine, one would see pupillary dilation. So this patient, because he had a lesion in his third order neuron, because he had a bullet that went through his carotid, this is the pattern that one would observe. Pupillary dilation only to neosynephrine or to atropine. So one additional consideration when talking about the pharmacology of all of these receptors is to recognize that almost all of them utilize G proteins. So we talked about G proteins in some detail in a previous lecture, and here we see their utility again. All beta receptors use the G sub S system, and as you recall, the G sub S system acts to increase cyclic AMP levels. Beta 1 receptors, which are found mostly in the heart, and beta 2 receptors, as we've discussed, found on smooth muscle, in the arterioles, bronchioles, to a certain degree in veins. These are all driven by by cyclic AMP, which is coupled to the G sub S system. Alpha-1 receptors, found mostly in vascular smooth muscle, will drive the G sub Q system, which, as we've learned previously, will activate the production of IP3. Alpha-2 receptors, found primarily in the CNS, will use the G sub I system, which will decrease cyclic AMP production. And an example of that is shown in the next slide. Here we have a central norepinephrine secreting neuron. These alpha-2 receptors shown here are found presynaptically. Presynaptic activation of the alpha-2 receptors will decrease cyclic AMP production, which will ultimately result in the lowered production and release of norepinephrine from this population of neurons. Muscarinic receptors come in various subtypes. There are M1 through M5 that will concern us here. M1, M3, and M5 utilize the G sub Q system. G sub Q system will lead to an increase in IP3 levels. These are the receptors found in the varied smooth muscles and various glands we've talked about today. M2 and M4 will activate the G sub I system. This G sub I system will act to open potassium channels. Again, these are metabotropic receptors such that they do not consist of an ion channel themselves, but they can indirectly alter the activity of particular channels, as is the case here. And you'll talk more about the M2 activation in the context of your cardiac physiology lectures. Nicotinic receptors, as we've talked about, are ionotropic. These are found on the autonomic ganglia, and again, these will directly open up cation channels for synaptic transmission. This concludes our descriptions of several examples of autonomic pathology.